Hi, I'm Pat Garrity, a medical technologist and an instructor of clinical hematology.
And I'm Jerry Walters, and I'm the hematology supervisor in a clinical laboratory.
Jerry and I decided to do this videotape after having been asked to be an expert witness for a hospital out on the West Coast. What they wanted us to do was describe to the court what the standard of the industry was for red blood cell morphology reporting. We canvassed the whole country, and surprisingly, we found that there was no standard.
Well, maybe it wasn't so surprising, actually, because none of us have ever addressed the problem before. But we received in the mail a lot of procedures from a lot of people who were willing to share their red cell morphology procedure with us, and we probably had a stack about this big, and no two were the same. So we decided this was really an issue that needed to be addressed because none of us knew what the other person was doing.
As we begin to go through this video, we would suggest that you look at the documentation that we have enclosed with it. There are most of the graphs, and there's also a procedure listed at the end of the documentation, which you would be welcome to use as your procedure in your own institution. Before we start actually talking about red cell morphology reporting, we have to talk about the RDW, which is called the red blood cell distribution width. It's a fairly new parameter that's generated on new age hematology instruments. To be able to standardize red blood cell morphology reporting, we feel that you have to have an understanding of this parameter. Actually, there are two parameters, and Jerry's going to explain to you the differences and the similarities of the two.
At present, there are two RDWs in use, the RDW-CV, which stands for coefficient of variation, and the RDW-SD, which means standard deviation. Most of us are probably more familiar with the RDW-CV just because it's been out there longer and in use longer. And there are some similarities between these two RDWs, but there are also some distinct differences. One of the differences is in how they are determined. The RDW-SD is an actual measure of how wide the red cell curve is at a point 20% above the baseline. It's very much like taking a ruler and measuring the width of the curve from one side to the other at a point 20% above where the curve starts at the bottom. The normal RDW-SD is about 39 to 49, and it's reported in femtoliters. Now, the RDW-SD measurement is not going to depend where on the MCV scale your red cell curve lies. Imagine if I took this same identical curve and shifted it to the left, say down to an MCV of 70, or to the right up to an MCV of 110. When I take my ruler and measure the width of the curve, I am still going to get the same measurement, no matter where it lies on the MCV scale. The RDW-CV is a mathematical calculation, which makes sense because in order to get a coefficient of variation, you have to use math. It is calculated by first determining what a 1 SD variation of red cells around the mean or midpoint of this peak is. The one standard deviation is then divided by the MCV and multiplied by 100 to get your result in percent. The normal RDW-CV is usually around 12 to 14.5%. Now, the key word here is divide by the MCV. This math makes the RDW-CV somewhat dependent on where on the MCV scale your red cell curve is. If we do the same thing with this curve, imagine if I move this same identical width curve to the left on my MCV scale down to an MCV of 70, or to the right up to an MCV of 110. Because I have the exact same curve, I still have the same 1 SD measurement. But now I'm going to divide that 1 SD measurement by either 70 for the microcytic MCV or 110 for the macrocytic MCV. This is going to have an effect on my final RDW-CV result. These three curves probably show this effect of the MCV better than I can explain it. These are three identical curves, and we know they're identical because they were generated on a computer, and hopefully computers never lie. They are different, they look different because they are merely placed in different spots on the MCV scale. You will notice the RDW-SD measurements are all the same, 52 femtoliters, because the curves are identical, and when we measure the width of the curve, we will get the same measurements. The RDW-CVs, however, are drastically different. They vary from 12% to 21.2%. This variance is due to the wide variance we have in the MCVs of these three red cell curves. When we divide our one standard deviation by 65 femtoliters, we get a RDW-CV of 21%, and when we divide by an MCV of 115, we lower that RDW-CV to 12%. Now, one of the uses proposed for the RDW-CV was to help classify anemias, specifically to help differentiate iron deficiency from thalassemia. Both the RDWs can be used to help classify the anemias, and they have some success, but certainly are not foolproof. But this talk is not supposed to be about anemias, it's supposed to be about morphology, and you're probably wondering when we're going to get there. And therein lies the problem. It was also proposed and published that the RDW-CV was the equivalent of anisocytosis. And some of us probably struggled with this for a period of time because what we saw on the smear and on the red cell curve was not always reflected in the RDW-CV. So Pat here, who has the mathematical brain, went to work. I tend to think math is a foreign language. But she did some manipulations and figured out how we could hopefully show you where the hazards are in the theory that the RDW-CV is the same as anisocytosis.
What we first did was run 397 samples on the Sysmex NE8000. We chose that instrument because it generates both an RDW-CV and an RDW-SD at the same time. So we had the data for each patient at the same time. What we did was we plotted the RDW-SD versus the RDW-CV. From the graph, you can see that we certainly didn't get a straight line, which you would expect if they really did correlate. In fact, when we did the correlation studies, the R-squared was 0.52, which certainly does not indicate very good correlation. What we then did was start to look at it more closely, and suddenly we realized, and this didn't take really a lot of thought once we went through it, we could manipulate the formula that Jerry just presented you for calculating the RDW-CV. Remember, that was the RDW-CV equals the 1SD divided by the MCV times 100. Well, all you have to do is shift things around, and you can come up with actually getting the 1SD measurement by saying 1SD equals the RDW-CV times the MCV divided by 100. We did this for all of the samples, and we came up with what that 1SD measure was. We refer to that, we had to come up with a name for it, and we refer to that as the Math 1SD. We then plotted that against the RDW-SD, and we found that there was very good correlation. The R-squared for that was 0.98, and you can see visually that there is almost a straight line. We also calculated the results for just the patients that had a normal MCV and those that were macrocytic or microcytic. You really wouldn't expect those R values to change since they were so good to begin with the whole population, and they didn't. They were the same. We then did the same thing comparing the RDW-CV to this Math 1SD. Now in this sample we have more patients. We have 779 samples, and that's because we included samples both on the NE8000 and from the Coulter Stack S. We had looked at the RDW-CV measurements from these two instruments and found out that they were equivalent measures. So we have more samples in this database. And if you look at the curve or the plot, we really do not have a very good straight line. In fact, we have more of a blob. The R-squared on this population was 0.61, which is also not very good, which tells us we have poor correlation between the RDW-CV and this Math 1SD. Well, if we separate out those samples with a normal MCV, and there were 446 of those, from the samples that have an abnormal MCV, and there were 333 of those samples, we can see what happens to the RDW-CV. This plot, we have only the normal MCV samples, and now we see a much better line. It is not perfect, of course, but it is much improved. And the R-squared is now 0.89, which also shows we have much better correlation.
When we plot those samples that have a macrocytic MCV, we can see that it tends to decrease the RDW-CV, and when we plot those samples with a microcytic MCV, we can see that it tends to inflate the RDW-CV value. Hence, when we compare all of the samples, that's why we get an R-squared of only 0.61. So if the theory is RDW-CV is the equivalent of anisocytosis, it really only has an association when the MCV is in the normal range. The hazards occur when your MCV is abnormal.
We're now going to show you some patient examples so you can apply this to the real world.
These are 3 patient red cell curves that were generated on the NE8000. Visually, when you look at them, you should be able to see that they are different. The first curve is fairly normal. The middle curve is a little bit broader than the first curve, and the curve to your far right is certainly almost twice as wide as the curve on your left. If you look at the RDW-SDs, they correlate to the width of the curve. As the curve gets wider, the RDW-SD gets higher. And yet the RDW-CVs are all identical, right around 20%. This happens because of the differences in MCVs. Our curves range from a microcytic MCV to a macrocytic MCV. And because of the math involved, remember we're dividing our 1SD by that MCV, it has a significant effect on the RDW-CV. If RDW-CV is the same as aniso, this should be telling us that all 3 of these patients have the same degree of anisocytosis. When looking at the curves, they really tell us a different story.
The next 3 examples again were generated on the NE8000. As you can see, even visually, these curves look exactly the same. And if you look at the RDW-SD results, they are. The RDW-CVs, though, vary depending upon what the MCV is. And as you can see, as we go toward the right, the RDW-CV increases, which, if we were using that as an equivalent to anisocytosis, the example on the farthest right would have a significant amount of anisocytosis, whereas the one on the left would not. But yet all 3 are with the same width of the curve. The last example, and I'm sure there's a sigh of relief on your part.
I'm relieved.
The last example is of a Coulter stack S. There were 3 examples generated on that instrument. The Coulter stack S does not have the ability to do an RDW-SD, but we are able to calculate the Math1SD. If we look at these 3 curves, we can see that they obviously do not appear the same, although the RDW-CV is the same. But by calculating the Math1SD, we see that there are differences as far as the standard deviation is concerned. Now we would like to start talking about the procedure, the actual procedure for doing red cell morphology reporting.
And people probably thought we were never going to get there.
Finally.
Finally.
We would like to talk first about how the procedure is done, how you will go about looking through a microscope. After we do that, then we will talk about the various things that you hopefully will find or not find as you do your search.
We all know the first thing we need to do when we look at a blood smear is to scan it on a low power, preferably a 10 or 20x objective. And this is really a good idea because you can tell instantly if you have a lousy slide and send it back for a remake, and then you don't have to do that one. No, seriously, you need to know that you have a good slide, that you have an even distribution, that you have a fairly even stain. It's not all blue on one end and all red on the other. And there are some abnormalities, such as Rouleaux and red cell agglutination, that are much more apparent on a low power scan. They will not show up as readily when you are right down looking at the red cells. It's sort of like the story of you can't see the forest because you're standing right in front of a tree. If you are so close to the red cells, you cannot always pick up these abnormal patterns like Rouleaux and agglutination.
After you've done what I call window shopping under low power, then you need to go to a higher power to look more closely. If you have a 50x oil immersion, that would be your next choice. I realize that not every institution has a 50x oil, and if you don't, then you would start out with your 100X oil. If you have a 50X oil, though, you would want to look under at least 10 fields to just see what there is. If you find no abnormalities in that 10 field area and you feel like you've looked at a good portion of the slide, different areas of the slide, then you can just let that one go and move on to your next workload. If you do find something in that first 10 fields, you should continue to look to make sure that it actually repeats itself. And for many of the items that we'll talk about, you will actually need to go to the 100X to confirm their presence. As Jerry said, there's some things that you really do better looking at a broader area than at a narrower field. And we'll make those comments as we go into the specific ones. Now, the other thing that we want to talk about before we actually get into the procedure is what we're using for the criteria. In a lot of laboratories, we used 4 pluses, 1, 2, 3, and 4 plus. We've chosen to use a 3 plus criteria instead, 1 plus, 2 plus, 3 plus, or if you didn't deal with pluses or you don't want to deal with pluses, you can use occasional, moderate, or many. We eliminated that 4th category because we felt that when you have the 4th category, the middle 2 categories kind of blend into one another, and you end up having a 2 plus day or a 3 plus day depending upon your mood, and it causes to have less standardization within the department. By having only the 3 pluses, you are able better to be consistent amongst each other. Now, before we actually implemented this, we did work with physicians and pathologists.
And clinicians. We didn't make this up all by ourselves. We came up with, actually, we talked to physicians and clinicians first to find out what was important to them. And Pat and I talked about this a lot, and we finally felt that we sometimes beat ourselves over the head in the laboratory trying to delineate exact numbers of cell types that the physician really doesn't care about unless there's a lot of them there. So we did pass it by clinicians, pathologists, and tried to stay attuned to what was clinically significant. And clinically significant in some cases is probably very different than what we always considered laboratory significant. We think everything's laboratory significant.
The first of the morphologies that we want to talk about is anisocytosis. Some places that report out the RDWSD, they have eliminated using the term at all in their differential and smear review reporting of red blood cell morphology, and they just rely on the RDWSD. If you do have an RDWSD, that does work quite well. If you do have to put a plus or a comment after anisocytosis, you can see on your screen that we have listed what the RDWSD should be for it to be a 1 plus, 2 plus, or 3 plus. If you work in an institution that just generates an RDW-CV only, you can easily do the Math 1SD calculation, which we talked about in the last section, and then from there report out the anisocytosis based on that Math 1SD. If you work in an institution that does not generate an RDW at all, we recommend that you use the criteria for macrocytes and microcytes, which Jerry's going to talk about next.
Macrocytes and microcytes are graded usually in a fairly broad range. And you'll notice as we go through the different criteria, we really only have 2 ranges. A broad range for cell types that need to occur in considerable numbers to be significant, and then a much narrower range for those cells which are important even when they occur in very low numbers. And Pat and I have kind of fallen into the habit of calling these lumpers and splitters. The lumpers are the things that you need to see quite a few for it to be important. The splitters are the cell types that are important even though you see a very few of them. And macrocytes and microcytes are 2 of the lumpers. If you see between 10 and 50 cells in your field that are either abnormally large or abnormally small, it's a 1 plus macrocytosis or microcytosis. If you see between 50 and 100 cells, or 1/4 to 1/2 of your field are small or large, it's a 2 plus. And when you see more than 100 abnormally sized cells in your field, and hopefully you have a field with the correct number of red cells in. When you see more than 100, you can really stop counting. If it's more than 50% of your field, you know you have a 3+. This patient example has a 1+ macrocytosis and 1+ microcytes. Now, some of the macrocytes are so large that it makes all the rest of the red cells look small. And in cases where you have a wide disparity of size, it's a good idea to compare them to a normal small lymphocyte. A normal red cell will be about the size of a lymphocyte nucleus. And if you look at that on this patient, you can see that a lot of these red cells are normal size. The extremes just make them look much smaller.
The next area that we want to talk about is hypochromia. Hypochromia is another one of, as Jerry and I refer to it, a lumper, meaning that we have to see a lot of hypochromia before we make any comment on it at all. And for all the lumpers, we use the same criteria. So as Jerry said, like 10 to 50 cells or up to a quarter of the field would have to contain hypochromic cells for it to be considered important. If you do see hypochromia, one of the things that you also have to worry about is not the intensity of the hypochromia, but just the number of the cells that are hypochromic. If we look at this example, we'll see that it's quite simple to evaluate because over half of the field has hypochromia, so right away it's a 3+. We don't have to spend a lot of time enumerating when we see more than 50% of the field having that particular abnormality.
Polychromia, the next section, or polychromasia or polychromatophilia. Pat assures me the words all mean the same thing. I don't know why we have 3 words for the same thing. But polychromia is the first splitter we're going to address. These are cells that when they occur in low numbers are clinically significant. So the criteria is a little bit different. If the average number of cells you see in your field that are polychromatophilic are less than 1 to 2 cells, it is a 1+. And why we say less than 1 is, say you look at 10 fields and you only see 2 or 3 polychromatophilic cells. Well, the first thing you would do is look at another 10 fields, and if you saw the same thing, just 2 or 3, obviously your average would be less than 1 cell. You're going to have like 0.2 cells for an average. This is still clinically significant because polychromatophilic cells really aren't supposed to be there. If you saw between 2 and 5 cells on an average per field, it would be a 2+ poly. And if you saw more than 5 cells per field, you could again stop counting. It's 3+, and you need not go any further. In this patient example, we have 4 polychromatophilic cells in this field. And according to the criteria, that would be a 2+ if this is typical of the fields you see in this patient.
The next morphology criteria that we're going to be talking about are inclusion bodies. In inclusion bodies, we've split up just a little bit, and the 3 that I'm going to talk about are basophilic stippling, Hal-Jolly bodies, and Pappenheimer bodies. You notice we call them Pappenheimer bodies and not siderocytes. If we're using right stain smears, the proper term to use is Pappenheimer bodies. We should really only use the term siderocytes if we have confirmed their finding on iron stain. I realize many of you probably do use the term siderocytes, but the correct term is Pappenheimer bodies when viewing under right stain smears. When we look at this slide, we can see the basophilic stippling, and we would realize that this would probably be a 1+ because there are only 2 in this field. This next slide of Hal-Jolly bodies, you can see the presence of them in this field. Hal-Jolly bodies are very important. They, I think, I always thought until recently they were kind of fun because you always could feel confident when you saw Hal-Jolly bodies. Hal-Jolly bodies, if you even see them in very low numbers, must be reported correctly because the physician bases a lot of the patient's splenic function on the presence or absence of Hal-Jolly bodies. I think you have to be assured that they're there, meaning that if you see 1, that really is not enough to call. You'd have to look around for that second Hal-Jolly body. In fact, Jerry and I have discussions about this, and she says, how long would I look around?
So if you only saw 1, how far would you look? And she told me forever. which is obviously not practical. You can tell she teaches and I work. We obviously can't look at slides forever, but it's true. If you just see one, you really, and I told her, I would obviously cover most of the territory on that slide. If I saw one Howell Jolly body, I would almost be compulsive about confirming its presence.
And I think it is important not to call it on just one, because it could be an artifact, something sitting on top of the cell. And in fact, I didn't realize how important they were until recently.
Some inclusions are important just because they're there. These include Cabot rings, hemoglobin C crystals, and malarial parasites. And these things can be reported as present. They are significant whether they are there in few numbers or a lot of numbers. We would love to show you a picture of a Cabot ring, but first of all, Pat doesn't believe they exist. She believes that all those pictures you've seen of Cabot rings in books, they have drawn the Cabot ring on top of the cell.
Absolutely.
I have only seen in my career, which is longer than I care to admit, one maybe Cabot ring. So because I think I've seen one, I think they exist. Pat thinks they don't exist. But we can show you a good example of a hemoglobin C crystal. And this is really a fairly perfect one. You don't always find ones this perfect, but when you do see them, it is important to note that they are there. The same is true of malarial parasites. In the center of this field is a malarial parasite. And it's certainly important to note that these are present. Now, on very rare occasions, a physician may want to know the level of parasitemia or the number of parasites per volume of red cells. It is going to be much more accurate to do a parasitemia count just as you would do a reticulocyte count. Enumerate the number of parasites you see per 1,000 red cells and report them as a percent of the red cells. It'll be a much more accurate indication for him than trying to grade it according to a morphology scheme.
The next abnormality we want to talk about is poikilocytosis. If you notice on the procedure, we have not enumerated the term poikilocytosis. In other words, we don't grade that general term poikilocytosis, misshapen cells. We feel that it's much more important to just grade what type of misshapen cell there is instead of giving a general number for poikilocytosis. And in fact, in places that did use poikilocytosis that I'm familiar with, we sometimes had a lot of problems because if you reported out 2+ poikilocytosis and then 1+ spherocytes, 1+ schizocytes, and 2+ Burr cells, it's like, how can you have 2+ poikilocytosis and all of the miscellaneous items underneath it equaling 4 or 5 or even 6+? So it really does not give the physician any added information to grade poikilocytosis as itself, but what's important are the specific types of misshapen cells. For poikilocytosis, there are really two. There are the lumpers and there are the splitters. But the lumpers are Burr cells, ovalocytes, stomatocytes, and target cells. And these are not important unless we see them in large numbers. Looking at this photomicrograph, we can see a lot of ovalocytes, and it's quite simple, in fact, to know that it's 3+ right away, because certainly more than half of the field have ovalocytes. The only important thing you have to worry about when you start to call ovalocytes is that they are going in many different directions, and they're not an artifact from a heavy hand making the slide. On this photomicrograph, you can see many target cells. And again, there are so many in this field that it's simple to evaluate because it's more than half, which becomes 3+.
The types of poik that are significant in low numbers are schizocytes, sickle cells, spherocytes, teardrops, pinchured cells, and blister cells. Now, this first slide, which shows you an acanthocyte, acanthocytes should be differentiated from Burr cells because acanthocytes are important when they occur in very low numbers and Burr cells are not. Burr cells frequently occur as an artifact, and that's why you need to really view the whole slide to make sure you don't have Burr cells created on one side of the slide. Acanthocytes, I don't think ever really form because of artifact. In fact, if you focus up and down on acanthocytes, you will see they are really three-dimensional cells, and the little projections come out from the sides and the top of the cell. In this next slide, we see a patient who has schizocytes, which are also important in low numbers. Now, some people believe it is important to identify the schizocytes according to their shape, whether they are helmet cells or triangular forms. These can be reported as present if this is an important finding or you feel it's important to record. But you have to remember that the most common cause of almost all schizocytes is fibrin damage. So it's not so much what shape the cell is in. What's important is that the cell has been damaged and fragmented and should be recognized as a schizocyte. Spherocytes are another splitter, a cell type that when they occur in very low numbers are clinically significant. In this patient with spherocytes, we see some definite spherocytes, but they are one of the cells that, oddly enough, when you approach it from a further view, say a lower power, spherocytes frequently stand out much more than when you are at a very high or close power.
Now we would like to talk about a couple of other things that don't fit into the morphology that we've talked about above. We called it other for lack of a better term. Two of them that I want to talk about are Rouleaux and agglutination. Both of those are really much more obvious on a low power. And if you remember, Jerry, when she was talking about the procedure, talked about when you're looking under the lowest power, 10x, you much more obviously see both of these. On this slide, you can obviously see the Rouleaux that is there. On this slide, the agglutination is very obvious. Now with agglutination, you do have to worry about your other red blood cell parameters being very thrown off. There are some things that you can do sometimes that will help. One would be to pre-warm the sample, or another would be to have to wash and replace the plasma.
A double cell population is another finding that if you see it, it really should be reported as present. Double cell populations occur for a couple of different reasons, and some of the more sophisticated analyzers on the market will flag these as dimorphic population. This example is a patient who has a microcytic hypochromic population of cells along with a normal population of cells. This is usually due to transfusion, or they can also be seen following treatment or therapy for things like iron deficiency or B12 or folate deficiency. If you see polychromatophilic cells in this double cell population, it suggests more therapy and a bone marrow response rather than transfusion. Now, there are a couple of cell counters, the more sophisticated ones available today, specifically the Sysmex and the Technicon analyzers, that can generate more information when they recognize one of these double cell populations. They can enumerate and give you the average cell size and number of red cells in each of these separate populations. And if you have this information available, it's probably a good idea to use it because it can be helpful, especially when you're following therapy and treatment, to see how a patient's responding, how many new cells are being made, etc.
Now, we'd just like to show you a couple of patient slides and apply what we've been talking about as far as using the standardization for reporting the red blood cell morphology. On this first patient, you can see obviously that there are differences in cell size. On this patient, I would call 2+ macrocytes and 2+ microcytes, meaning that between 25 and 50% of the cells are both macrocytic and another 25 to 50% of the cells are microcytic.
The patient also has schizocytes and spherocytes. Now, the schizocyte part is easy to do because there are 3+ schizocytes, and once I get up to 5, an average of 5 per field, I'm really done counting. Spherocytes I would grade as 1+. There is an average from less than 1 to 2 cells per high power field.
Also, there are punctured red blood cells, and again, there aren't that many, and there is less than 1 to 2, so we would do 1+. And there are teardrops, and with teardrops, it's like ovalocytes. You have to worry about them going in different directions from the way the slide was made, and they obviously are in this, and there would be 2+ in this patient. Remember, this is a representative field. We would have to see these things repeat themselves in other fields. This next slide is a patient who has hereditary Poikilocytosis. Jerry suggested that I say the word. She was afraid her tongue would get too twisted with that term. If we look at this, right away, it's like you just want to say 3 plus everything and be finished with it. But really, we have to stop and analyze carefully each one of the criteria. This patient has 3 plus microcytes, meaning more than 50% of the cells are microcytic, and 1 plus macrocytes.
The patient also has 3 plus schizocytes and 3 plus spherocytes, and I got the easy part of the job here because once I get up to 5 per field for either cell type, I'm at the maximum and I have a 3 plus.
This patient also has pinched and teardrops, and again, there's so many that they're 3 plus. And if we look around, there are also ovalocytes, but not as many, so that would be 2 plus. Remember, ovalocytes are in the lumper category, so we would have to see quite a few before they mean anything.
This patient also had a 3 plus polychromia, and it may not be real visible on your screen because of the wide disparity in cell sizes, shapes, and intensities. But there are quite a few cells. In fact, most of the very large cells in this field are polychromatophilic. So the patient would also have a 3 plus poly. Now, for those of us who have tried to add up our POIK over the years, I want you to note that we have now given this patient a 14 plus POIK.
Not a 3 or 4 plus. And you can understand how it really does work out much better not to call the general poikilocytosis, but to be specific, or we would have to say 14 plus POIK. Crazy.
Nobody'd believe us.
No, but when we look at the slide, we know we have to just about call everything. We'd like to thank you very much for listening to this tape, and we hope that it's helpful to you in standardizing your red blood cell morphology reporting procedure.
We'd also like to thank you for staying awake if you did, and we also hope that standardizing your morphology reporting will be helpful to the clinician. We have to remember that physicians generally don't practice at any one hospital, but see patients at a variety of hospitals, and this certainly we hope will be helpful to them.